The title of this talk is A Child with Eye Deviation. This case was initially presented by Dr. Rudolf Wagner. I will use it for pediatric neurology rounds. The first thing I'd like you to notice in this photograph is the hand of the physician holding the head of the child straight up. Now look at the right eye. Notice there is no white under the iris. Now look at the left eye. Notice that there is a lot of white under the iris. This ocular misalignment is further documented in this frame by the horizontal lines drawn at the pupil's equators. This misalignment has one of three possible explanations. Either the muscles depressing the left eye, the superior oblique, the inferior rectus, or both are weak, or the muscles elevating the right eye, the superior rectus, the inferior oblique, or both are weak, or the right inferior rectus, inferior oblique, or both muscles are entrapped at the floor of the orbit, and the entrapment is physically preventing the elevation of the right eye. Now, let's suppose that we are able to use a pair of glasses with transparent red and green crystals, and to put these glasses in such a way that the transparent red crystal is in front of the right eye and the transparent green crystal is in front of the left eye, as I have illustrated in this frame. Now, let's further imagine that we place a white bright bar at a distance of about 2 feet from the patient in the horizontal position, as I have represented here, and that we could see what the patient is seeing when the patient looks at the bar. Such being the case, we would see that the patient is seeing a horizontal red bar and a tilted green bar below the red bar. Now let's see what happens when the patient's face is no longer held straight up by the physician's hand. As you can see in this new photograph, left to her own will, the patient tilts her head to the right. In this position, you see no white under the iris in the right eye, nor in the left eye. This is so because when the head is tilted in this position, both eyes are aligned. And were we now to use the same color glasses and place a bright horizontal white bar about 2 feet in front of the patient, as we did previously, the patient would see a single yellow bar, the yellow corresponding to the color formed by the fusion of the red and green images in her brain. Now, in addition to the glasses, I like to introduce a second tool, the ophthalmoscope. Were we to do a fundoscopic exam of the right eye with the head straight up, we would see the retina and in it the disc and the fovea. Were we to draw a line in the equator of the fovea and prolong that line past the disc, as you can see in this frame, we will see that the distance between the line and the upper pole of the disc is twice as long as the distance from the line to the lower pole of the disc. In other words, the line would fall 2/3 from the top and 1/3 from the bottom of the disc. This disc fovea altitudinal relation is normal. Now, if we look at the left eye, we would see the left retina, the disc, and the fovea. Were we at this point to repeat the exercise we did in the right retina by placing a line in the equator of the fovea and then prolonging it towards the disc, we will see that the line is barely touching the disc at its lower pole. This disc fovea altitudinal relation is abnormal. The abnormality consists of the fovea being lower than it should be in relation to the disc. Such abnormality indicates the presence of cycloduction. So, what does this mean? To start answering this question, let's look at the right eye, which, as you know, based on the fovea disc altitudinal relation, is normal. A fact that I have displayed by drawing a vertical line going through the middle of the pupil perpendicular to the ground. Normal eye torsion results when the forces producing in cycloduction generated by the contraction of the muscles inserted at the top of the eyeball, the superior oblique, and the superior rectus, or both, are equal to the force producing cycloduction generated by the contraction of the muscles inserting at the bottom of the eyeball, the inferior oblique, inferior rectus, or both. Now let's look at the left eye, where cycloduction forces, as we saw by fundoscopy, prevail. Cycloduction prevails because the forces producing it are stronger than those producing in cycloduction. A fact that we are representing by a yellow line going through the center of the pupil, but with the top tilted towards the ear. So, since we know which is the abnormal eye, the left, that the left eye shows cycloduction when the head is straight, and that of the two potentially weak depressor muscles, the inferior rectus and the superior oblique. Only the superior oblique produces in cycloduction, we can conclude that the left superior oblique is the weak muscle, the cause of cycloduction and of the ocular misalignment. This conclusion is further supported by two additional observations. The first one we have already alluded to. It is the preferred direction of the head tilt. Notice that the head tilt is towards the contralateral side of the affected eye, a position known for achieving binocular single vision in patients with left superior oblique palsy. And the second observation, which I will show you in a minute, is the correction of the fovea disc altitudinal relation with the head tilt. When fundoscopy is performed with the patient in the right tilt position, the relation between the disc and the fovea, which can be seen here, is normal in the right eye. Is also normal in the left eye, or if not normal, at least at the same fovea disc altitudinal level, which is also known to occur in cases of superior oblique palsy. Binocular single vision and normal disc fovea altitudinal relation is achieved by tilting the head to the opposite side of the affected eye because this position corrects the visual axis. This is so because in this position, binocular, single vision, and disc fovea alignment is achieved without the need for left eye in cycloduction, elevation, nor abduction. Thus, the failure of the superior oblique actions has no bearing on the patient's visual axis. I will show you why this is so in the next few minutes. The loss of the depressor function of the superior oblique is compensated by the fact that the left eye with the head in this position is higher than the right eye. This seemingly paradoxical situation that the elevation of the abnormally elevated eye improves the visual axis occurs because in this position the abnormal cycloduction corresponds to a degree of torsion that can be compensated by the normal eye in order to reach a normal visual axis. The loss of the abduction function of the superior oblique is compensated by the fact that the left eye horizontal position with the head tilted to the right is solely dependent on the balance between the abduction actions of the lateral rectus and the inferior oblique and the adduction actions of the medial rectus and the superior rectus. The compensation for the loss of superior oblique in cycloduction will be illustrated in the next few frames. As you can see, I have placed a magenta arrow to represent the trajectory of the left eye as the head is tilted. In this new frame, I have introduced a segment of the photograph corresponding to the left eye with the head straight up. Notice the inclination of the yellow line. Notice that as it changes position following the designated trajectory, the line is progressively becoming more perpendicular and ultimately it reaches a vertical position perpendicular to the ground. Now I would like to ask you a question. Would her double vision be worse on right or left lateral gaze? These boxes correspond to the 9 eye positions of gaze. At this point, I would like to consider only 3 of them: primary position, left lateral gaze, and right lateral gaze. I have now introduced the photograph of our patient's eye in primary position. And now a cartoon reflecting her eye findings. This cartoon includes the extraocular muscles and arrows pointing in different directions, as you can see. The direction of the arrows indicate their action. The extraocular muscles and the arrows are color matched, so the color of the arrows indicate the action of the same color muscle. For example, the action of the lateral rectus, represented in cream color, is to abduct the eye, as represented by the outgoing arrow colored cream. The placement of the arrows around the eyes indicate their site of maximal action. For example, the inferior oblique site of maximal action is when the eye is adducted. The superior rectus site maximal action is when the eye is abducted. Both the superior rectus and the inferior oblique contribute equally to eye elevation when the eye is midline. I will now explain the relation between this cartoon and the patient's findings. We know that the left superior oblique, which I have now colored red, is weak or paralyzed. And as a consequence, since only one of the two muscles depressing the left eye is working well, the left eye will be elevated by the overpowering force of the elevators, the superior rectus, and the inferior oblique. On left lateral gaze, the story is a little different. As you can see in the left lateral gaze box, I am representing the eyes in the same arrangement encountered in primary position. I have done so to illustrate the changes brought about by gazing to the left. The normal right eye will adduct and be kept at the equator because the forces generated by the eye elevators and depressors are equal. On the other hand, the abnormal left eye on left lateral gaze will abduct because of the lateral rectus is normal. The eye will also come down some from its abnormal elevated position in primary position, but not as far down as to reach the equator. This is so because although the prevailing muscles influencing vertical position of the abducted eye are the superior rectus and the inferior rectus, and both are working well, there's still, even during abduction, some residual depressor deficit brought about by the imbalance between the weakness of the superior oblique and the normal force generated by the inferior oblique. Now let's see what happens during sustained right lateral gaze. As I did before, when talking about left lateral gaze, in this frame I have introduced a cartoon of the eyes in primary position. I have done so to illustrate and explain what happens during right lateral gaze. So let us first look at the normal right eye, which upon gazing to the right will achieve its normal abducted position at the equatorial region. Now let's look at the abnormal left eye. This eye will adduct normally because of the overwhelming adduction force created by the contraction of the medial rectus muscle, but as it moves towards adduction, the elevation becomes more pronounced. This is so because when the eye is adducted, the vertical position of the eye is predominantly the result, in this case, of the imbalance between the normal force generated by the inferior oblique and the lack or weak force generated by the abnormal superior oblique, and less so by the influence of the balance of the forces generated by the superior and inferior recti, whose influence is more when the eye is in the meridian because their influence wanes as the eyes are adducted. So the answer to this question is her double vision would be worse on right lateral gaze. Now I would like to ask you another question. Would her double vision be worse on up or down gaze? Again, I will use the 9 box diagram to illustrate the effect of up and down gaze in this patient with left superior oblique palsy. When looking up, the normal eye will, of course, move up normally. The abnormal eye, already up because of the pre-existing depressor weakness brought about by the weak superior oblique, will elevate since the levator muscles are not affected. Thus, the misalignment will be less than it was in the primary position, especially so if the patient uses the abnormal eye for fixation, in which case binocular single vision will be achieved. It is also worth mentioning that the horizontal position of the eye will be midline because the abduction force generated by the lateral rectus and the inferior oblique will be matched by the adduction force generated by the medial rectus and the superior rectus. A similar argument holds for the torsional position of the eye. In up gaze, the torsional position of the eye is held by the torsional forces generated by the inferior oblique and ex-cycloduction muscle and the superior rectus and in-cycloduction muscle. Hence, in up gaze, the horizontal and torsional force imbalance created by the weak superior oblique has no clinical consequence. During down gaze, as illustrated here, the normal eye will go down normally. The abnormal eye, because of one of the depressor, the superior oblique is weak, will only move down halfway and adduct slightly because the adduction function of the inferior rectus will not be counterbalanced by the abduction function of the damaged superior oblique. In normal situation, the horizontal position of the eye during down gaze is greatly influenced by the balance between the forces generated by the superior oblique and the inferior rectus. For similar reasons, the stronger contribution of the superior oblique and inferior rectus to the torsional position of the eye in the lower gaze than in primary position, the eye will be more ex-cycloducted in the down gaze than in primary position, as represented by the just added yellow lines in this frame. So the answer to this question is that her double vision would be worse on down gaze than on up gaze. Now, I have one last question. Would her double vision be worse looking down to the right or to the left? We will start analyzing the left down gaze. We will start with the cartoon representation of the eye in primary position. The right eye, being normal, will move appropriately. The left eye will abduct normally from its superior position, then will depress almost to the same level as the normal eye, because in abduction, depression is the primary function of the inferior rectus, which is normal. In addition, the eye will minimally adduct and ex-cycloduct because of the more prominent contribution to those actions created by the imbalance between the inferior rectus and the superior oblique in the down gaze than when the eye is in primary position. Now we will start analyzing the right down gaze. I have now introduced a representation of the eyes in primary position to explain the changes that occurred when looking down and to the right. The right eye, being normal, moved to the lower right corner. The left eye will move medially since the medial rectus is normal, and then come down, but not as far as it did when looking straight down, because in the adducted position, the influence of the inferior rectus and superior rectus is less, and the ultimate vertical position depends mainly on the interaction of the weak superior oblique and the normal inferior oblique. In addition, there will be slight adduction and excycloduction of the left eye. The reason this is so, as we stated when talking about left down gaze, is because in normal situations, in right down gaze, the adductional and excycloductional forces generated by the inferior rectus are balanced by the abductional and encycloductional forces of the superior oblique. But since in this case the superior oblique is weak, the ultimate horizontal and torsional positions is dominated by the forces generated by the unopposed inferior rectus. So the answer to this question is her double vision will be worse in right down lateral gaze than in left down lateral gaze. As a matter of fact, of all gaze positions, in patients with left superior oblique palsy, double vision will be worse in right down lateral gaze. To finish up, I will introduce a table that summarizes the extraocular muscle functions. As you can see, the lateral rectus and the medial rectus only have one function each. The lateral rectus abducts, the medial rectus adducts. The rest of the muscles have three functions each. The superior rectus elevates, intorts, and adducts the eye. These intorsional and adductional functions of the superior rectus are only clinically significant when the eye is looking up. The inferior rectus depresses, extort, and adduct the eye. The extorsional and adductional functions are only clinically significant when the eye is looking down. The inferior oblique extorts, elevates, and abducts the eye. The extorsion and abducting actions are only clinically significant when the eye is looking up. The superior oblique intorts, depresses, and abducts the eye. The intorsion and abducting functions are only clinically significant when the eye is looking down. It is important not to confuse extraocular muscle functions with extraocular muscle starting point of maximal vertical action. The starting point of maximal vertical action of the inferior oblique and superior oblique is when the eye is adducted. The starting point of the maximal vertical action of the superior rectus and inferior rectus is when the eye is adducted. Thank you very much for your attention.